it is difficult if you have a very high-risk group of patients. And it's one thing if you know that at 3 months, the person who's in CR is going to be, is likely to be in CR at 1 year or 2 years, right? Then I think that makes the decision not to do something like an allogeneic transplant very easy, right? But now that we're starting to see fall-offs, one of the things that we have done, again, hoping for long-term remissions, is at times watch patients, and we have seen relapses. Now, those relapses have sometimes been responsive to a second CAR T-cell infusion. At times they've been limited in disease, even in patients who had highly bulky disease, and we could get them to a CR or near CR and then have taken these patients to allogeneic transplant. But the notion of CAR T-cell therapies as a bridge versus as an independent therapy is really a quite different process, I think, both emotionally for the patient and as we view it even in the health system. So.
Right, no, I think so. That's a major question right now. A major question right now, I think that's going to evolve is this a bridge? I mean, allogeneic transplant is still a curative treatment for a significant number of patients, not all, and it's not for everybody because of the potential toxicity. But as Michael alluded to earlier, this is with non-ablative allogeneic transplants, we can treat people into their 70s, and if they've got and donor availability isn't so much a problem. I mean, we estimate now 70% of patients ought to have a donor when you combine haploidentical matched SIB or matched unrelated.
I would go further. I would actually say that nearly every patient has a donor.
Yeah. Okay. So I think that I think that's not the issue, but the issue is, will they tolerate the transplant? Will they tolerate the CAR T? Is the CAR T curative? Is it only a bridge to transplant? I don't know the answer to that.
Yeah, and I want to make a point about I think transplant eligible versus ineligible. We are now not using non-myeloablative, as Michael talked about with FCR regimens in low-grade lymphoma. We can't do that in aggressive lymphomas. You have to have more cytoreduction. So we use regimens that are ablative. That is, if you gave this chemotherapy, you would not get hematopoietic recovery, but are reduced in their intensity. Like we typically would use fludarabine combined with melphalan at 140 per meter squared, and that's a pretty well tolerated regimen. The early 100-day mortality in a sibling population is under 5%, and we are doing allogeneic transplants in AML patients and in lymphoma patients up to the age of 75. Now, above 70, we look for clear fitness, but we really don't, exclude many patients under the age of 70. Yeah. So, and I think that's important for community physicians, because many community physicians think that their patients, we now estimate, in work that I'm doing with the American Society for Blood and Marrow Transplantation, that probably no more than 15% of acute myeloid leukemia patients are getting allogeneic transplants if you look at for example, insurance databases, and probably no more than 30% of myeloma patients, despite the fact that we've had data for 20 years that suggested that for many patients, myeloma autotransplant should be there. So I think that there is a lack of understanding, and I think that for the community physician who is wondering whether there's a role, I would say send the patient to us. We're not going to do a transplant in somebody where we think that we're going to do more harm than good. And often patients, and the referring physicians are surprised that a patient is transplant eligible because the transplant eligibility has changed dramatically in the last 20 years.
Right. One of the exciting things that's going to come from the CAR T cells is, and Leo alluded to it with the checkpoint inhibitors, and there's there are several abstracts at this meeting and papers that have been published that small molecules can restore T cell health, and the ibrutinib has the ability to do that and to make CAR T cells work better both in preclinical models and now this is being tested in studies. But it still gets that critical question: is this going to be curative or not? Until we get the answer, it's going to be hard to see doing this approach until patients are at a more advanced stage in their disease, don't you think?
No, I agree, and I think that another a significant point is really the cost of these therapies, especially if they are not curative therapies, and they are then applied in sequence with other therapies that have significant cost to the system, right? So if you're, I think the financial notion of CAR T cells as a curative one-time therapy is quite different. If you then now say that the patient needs an allogeneic transplant, and if that allogeneic transplant in the future might consist of maintenance therapy, right? So I think that these are really societal issues that we haven't fully addressed, but clearly we'll have to have the information going forward. I want to note a couple of things about the evolution of CAR T-cell therapies. There is a KITE study that's just now studied looking at, we talked about checkpoint inhibition in combination in the lymphoma setting, where again the rate of neurotoxicity appears to be lower of CD19 CAR T-cells in combination with atezolizumab to again try to again take the brakes off of those cells. And Carl June presented some preliminary preclinical data, but that's going to lead to a human trial where they're actually using CRISPR-Cas9 gene editing technologies to get rid of PD-1 on the surface of T cells, and also get rid of HLA class 1, which might be the first step toward an off-the-shelf CAR T cell, which would come from another donor. Therefore, if it doesn't have class 1 on it, it's less likely to get rejected. And that, I think that there's a lot. We clearly don't even know where they need to be applied or who's going to get cytokine release syndrome or how to optimally manage the neurotoxicity. But I do think that we will learn more about this. There are some interesting biomarker studies that are going to be presented in the late breaker in the KITE abstract, and certainly the Juno and Novartis groups are along with others, are really doing very detailed and thoughtful analyses of the correlates of toxicities, both cytokine release syndrome and neurotoxicity. And I do think that we are likely to get to the point where we can either predict which patients may have unacceptable rates of neurotoxicity or be able to intervene. Mike Jensen has data, for example, in Seattle, suggesting that very low doses of steroids given preemptively can be associated with decreased rates of cytokine release syndrome and neurotoxicity without compromising the efficacy of those cells. So I think these are all things that, to me, give me lots of hope, but there will be, I think, steps forward and backward on the way.